Hello, everyone, and welcome back. We'll be continuing on our study, and today I'll be presenting you if evidence on vulnerable populations. We'll be discussing children, then old age, and lastly, psychiatric populations. So I'll be sharing with you my slides, and I hope you can see it. Um, so, first of all, this is a very large topic in which it's very difficult to address in just one class, but I think it's quite obvious the things I'll be discussing with you. In a children population, the bigger problem we have is usually with lack of data and secondarily to the need of informed consent. And for children, usually we require parents and guardians to treat and to that they provide us with consent. And there are many interventions which seem very simple, like the use of melatonin, but still we would require that. Also, psychotherapeutical interventions require that we ask parents for the consent. And sometimes I'm seeing children in my practice. Although I'm an adult psychiatrist, I have a lot of my clients bringing in their 16-year-old, 15-year-old children, and usually I have to be careful because I need the assent of the child, and I need also the consent of the other parent. And this can get very complex when parents are not married and they do not share the same responsibilities. Sometimes they are divorced. Sometimes there's a legal arrangement about who is in charge of this child. So it's very hard to define who is responsible, who can decide. And as doctors, we can remove parental power transitorily if we feel that the child is not safely guarded by them in respect to their treatment. So this decision is also a very complex decision. In terms of assent, it's also very important because children should be sought, when possible, to decide also whether they want or not to have that intervention. You can imagine situations in which children have cancer, they are being submitted to chemotherapy or submitted to surgery, and sometimes surgery can be very violent, and it's very relevant that we can explain the situation to them. If children are young enough, sometimes explaining should be very age appropriate and age adequate because sometimes it's too hard for them to know. Behavioral interventions are also very important. So some researchers have raised ethical concerns about the fact that we are using psychotherapeutical interventions that can have short-term distress. And indeed, in that case, we should balance that short-term distress, which can be traumatic for children, with long-term sleep and behavioral improvements. So this is always a problem when we decide to treat children. If we decide to use drugs, it is true that melatonin is usually safe and effective. We have two ages in which it's very effective. It's like postmenopausal women and also children and adolescents. But it is definitely off-label, especially for those under 2 years old. And I have a lot of clients of mine that have been advised to use melatonin in very young children. And therefore, we should always measure the unknown long-term risks of this intervention. And when we think of melatonin, and this can make the same argument for other interventions, we need to ethically reason on are we using it appropriately? Um, is everyone that should be using it accessing it? So another ethical issue about melatonin is its price. It's very concerning the fact that it's so expensive. At least in Portugal, it's extremely expensive to use it. A very simple drug. Also, we should inform patients when melatonin is being used off-label. There is very limited evidence for on-label use of melatonin. And when we are addressing these issues, we need also to be concerning cultural sensitivity because different cultures require different forms of intervention. We can imagine Ramadan and in an Arabic country in which people do not sleep because they are awake during the night to eat because they cannot eat during the day. And we also have to address the fact that some people do not want to share this information with others. Again, as doctors, even if it looks a very simple information, we need to be always aware that there are limitations in what we can share and that sharing clinical information should be subsidiary. When we speak of children, sometimes we should discuss this possibility of informing parents about the difficulties their children are having. When it comes to the elderly, there are a lot of ethical dilemmas surrounding polypharmacy and the management of sleep. So first of all, um, we've discussed it extensively in the previous class, but this idea that there are a lot of adverse events that can happen due to the use of many drugs in childhood. There is a higher risk of falls, cognitive impairment, admissions to hospitals, and there is also burden that cannot be ignored and the potential of non-adherence. And most of these old clients, they do not adhere because they forget. So this is the paradox of treating people at late age, is that sometimes they forget. And the drugs we use for sleep are very relevant because I will always advise my clients to have support in their showers, to avoid having carpets, even to find ways that they can pee during the night, during the beginning of treatment, with help. Someone that wakes up with them and takes them to the toilet during the night, because sometimes they really can have hypotensive events with risks of fracture. Long-term use is very, very well known. Cognitive impairment during the use is also well known, although dementia, as I've discussed in the previous class, it's also a problem. The abrupt discontinuation that sometimes happen leads also to symptoms, and these symptoms can also be impacting. So you can imagine someone stopping abruptly because they forgot the drug when they were traveling to the north of Portugal or to a place where they cannot take it for some reason. And this discontinuation can provide them with anxiety, restlessness, and again, the risk of adverse events, as in driving, for instance. And we must tackle individual needs, which indeed sometimes circumstances do warrant that you use a benzodiazepine and sleep tablet, to a more evidence-based practice in which there is no guidelines supporting the use of benzodiazepine for chronic insomnia. So, of course, we need to address that the patient is not sleeping and we need to help him, but in the long run, you will need to really focus on cognitive behavioral therapy. And we as doctors will always fight to deprescribe. And deprescribe, this includes trying to reduce, taper things to avoid long-term use of drugs. And during this period, we need to be careful in the risk of recurrence and withdrawal effects. And again, melatonin has been something that has lower risk of side effects, but we really need to see because many times it's just an off-label use. And off-label use is always problematic. Lastly, I'll be speaking a bit about psychiatric care and the fact that sometimes we're treating sleep disorders in psychiatric illnesses, and we forget that there is a complex relations between these two situations. Sleep disturbance are symptoms of psychiatric disorders, and sleep disturbance can lead a patient to experience many psychiatric symptoms. For instance, a patient that has bipolar illness, if he stops sleeping because of a environmental reason, suddenly he will might have a manic trigger to become manic, and therefore there's a risk that insomnia leads to that. But again, a patient can have insomnia due to the severe stage of depression or due to trauma. So insomnia can exacerbate symptoms that we see in psychiatric illness, but also it can also hinder recovery. So sometimes insomnia is the last symptom of mental illness. Sometimes we treat depression, patients have improved, but they still have a problem. And therefore, we need to address this integrated approach between sleep medicine and psychiatric symptoms. We cannot treat sleep issues in isolation, and we can also not treat just psychiatric symptoms in isolation. They need to be tackled together. And again, most of the interventions we can offer to psychiatric diseases and sleep medicine include therapy. And sometimes we forget because therapy is like the Columbo's egg, because it's a situation in which we can understand better because we have more time with patients what is happening before we resort to medications such as those that have risk of dependency and adverse events. I would say that we always have sleep problems in the end of most psychiatric treatments. So sometimes after we treat the primary psychiatric condition, these ongoing issues can definitely lead to the patient have negative outcomes. So dealing with sleep is fundamental for treating psychiatric illnesses. And paradoxically, for instance, a patient with depression, if I give him a sleep tablet, he will sleep worse and feel very exhausted in the morning. So what improves quality of sleep is the use of an antidepressant in the morning. So you can imagine insomnia that is anxious, that would improve a lot with the benzodiazepine, while an insomnia that's due to depression does worsen very easily. So this is the final talk that I'm giving you before we get back together and discuss this together. Thank you for listening.